Good afternoon, wherever you are in the world. This is Matthew Holt, host of THCB Gang, and it has been quite a week. We're streaming live on the THCB and on YouTube. You may be listening on the podcast, but it is September the 24th. It is the THCB Gang, and I have a great lineup of regulars, or people I'm persuading to be regulars, a couple of them, and you'll see them all in a second. On the gang with me today, Grace Cordovano, regular and board certified patient advocate from New Jersey. Robin Farmanfarmaian, these days an entrepreneur, but well known as the author, patient advocate, and international speaker from Palo Alto. From Chicago, Michael Millenson, healthcare expert, president of Healthcare Quality Advisors, patient safety expert, and others. My old boss, Ian Morrison, well-known health futurist at Second Curve, and great to have back on Dan O'Neill, healthcare consultant and RWJF fellow. So we're going to go live, and I'm going to say to everyone, I mean, every week I say there was a crazy amount of stuff this week, but since last, I guess, Friday, I don't even know where to start. So, Ian, why don't you start?
Oh, man, it's so much. I mean, well, I'll make a list. I'm sure everybody's got the same starting list. You know, the passing of Ruth Bader Ginsburg and the implications for the Supreme Court and for the ACA. The weird week I've had is yesterday introducing at Arnie Milstein's internal deal at Stanford, the guy from RAND who did the RAND 3 study, and simultaneously doing a board retreat with John Muir at 4 o'clock after that. So that's kind of interesting. So I'm in the middle of all the RAND 3 stuff. You know, I think the events with Breonna Taylor's, you know, findings of the court or the grand jury, I think is going to have huge implications. And then the president's not going to leave ever. So apart from that, nothing. I got nothing.
No. Robin, what have you seen this week?
Besides, the Ruth passing, I've never actually mourned someone I've not met in person before. This is the very first time in my life that I'm actually mourning someone. But the big news that I'm watching, because I love the drone industry, is Walmart partnered with Quest, and they are working on delivering COVID tests to people using drones.
Hey,
like that is so cool in my world.
Is that Zipline? That's Zipline, right? Zipline, the guys who've been.
I think I didn't see who they partnered with. I'm not sure that they put that in the article. Well, yeah. Of course. I mean, Zipline's worth $1.2 billion. They've been they were founded in 2016, and they've been in Ghana and Rwanda for years, doing about 170 or so blood products, vaccines, medical supplies. And so, Zipline is a very well-established company to do this. But of course, Google Wing has their own. I mean, UPS is using Matternet. So there are a lot of different choices in the world of drones for them to partner with.
Wow, fantastic. Michael.
Let's see. Well, speaking of drones, it reminds me of Mitch McConnell. And I guess the other good news would be liberals are no longer worried about Justice Ginsburg's health. But in terms of where we're going, I think that if you look, to me, the big sort of hidden news is an Axios poll in which you ask people what they were worried about in the election. And healthcare comes in number 3, way down there. Now, you think, wait a second, how can that be? The economy is number 1, and the coronavirus is number 2. And if you think about it, all of it is connected, right? Why is the president talking about a vaccine incessantly? Because he wants to get the economy restarted, right? Why are we talking about the home test delivered by drone or carrier pigeon? And by the way, Walmart could have a headline that said, COVID, now airborne. Just a little marketing suggestion there, Robin. And so all of this revolves around, can we get the economy restarted? And even the ACA kinds of things that we're worried about from Justice Ginsburg is, to a certain extent, if I don't have a job, I'm really dependent on having access to no pre-existing condition and all the other kind of groups that I can get through the exchanges. If I do, maybe I'm not as worried. So wrap it all together and we can see that the kinds of issues we care about in terms of healthcare are intimately connected in the public mind to how is the economy going to restart. And I think that Axios poll where the words healthcare were like 8% really is a reminder to all of us about what's happening out there with people who are tremendously worried.
Grace, what's your week been like?
Ooh, so well, I'll stick to my corner of the world because everyone's touched on a couple of doozies. So I was excited to see and intrigued to see there's a woman in New York who filed a lawsuit against Health Alliance Hospital and our friend Ciox for declining access to her deceased husband's medical records. And this is something that I've been seeing on the COVID-19 front. What's happening is people don't have a personal representative, they don't have a will, and people have died. Over 200,000 people in the United States alone have died from COVID-19. And now the bills are coming in. So families are struggling with bills, and you can't appeal a bill, and you can't try to overturn a denial. You can't deal with workman's comp, Social Security disability, COBRA, all of these administrative and financial burdens without access to your medical records. In theory, you should have access, but it's trying to move a mountain when you're grieving the loss of one family member, and some families have lost multiple. So these bills are astronomical because when you think about what was happening here specifically in March in New Jersey, New York, we're talking weeks on ventilators, hundreds of days with specialized care. So it's interesting that we can't have that kind of information blocking, and I'm glad to see that we're still drawing more and more attention to the right of patient access.
No, huge point. Very important. Dan.
I'll try to stick to healthcare news, albeit sort of broadly defined. I'm certainly paying attention, like all of us, I think, to the impact of Justice Ginsburg's passing on the prospects for the ACA, with the Texas v. California scheduled to be heard just after the election. And then also, I think we've seen some interesting enrollment data come out of covered California on the individual market, which sort of just heightens the attention on the ACA's durability, as well as some of the Medicaid enrollment numbers. Families USA has some data out, all of which I think has us a little bit on pins and needles.
Well, it's amazing we got all the way through this with the three of us living out, or four of us living out in the Silicon Valley area, that we didn't notice that in all this chaos, stock market's having another crazy week. GoodRx, which is essentially a prescription card for the 21st century, came out and is now valued slightly more than Cardinal Health and slightly less than McKesson, two huge mega drug distributors. So I'm still very bitter because Doug Hirsch presented them at Health 2.0 the first time in 2012. And I said to him once, oh, where's my 10%? He said, yeah, we'll get you. Never got me. Not to mention that Amwell went public also last week and is traded up at least. So that's still going on, and that to me is like the dichotomy between what's happening on the stock market, which is still close to or at an all-time high. That's been up and down the last week with these incredible IPOs, valuing these companies which are either making losses or making, in GoodRx's case, a decent profit, but not with the staying power or anything like the revenue of the Cardinals or the McKessons or the companies they're grouped with, is going on. Yet now we're in stark relief with RBG's, very sad passing. You can go back and forth about whether she should have quit in 2013 or this, that, and the other. But nonetheless, I think we were all hoping and expecting that she would be able to resign and have some golden years under a Biden administration, but obviously that's taken away from us. And it's worth pointing out that even if they don't reseat her, and I assume it will happen, but we'll have to see. I didn't realize this, and I was back and forth with Larry Labert from the Kaiser Foundation on Twitter on Friday night. But a 4-4 vote. So even if Roberts came over and voted to continue the ACA, if the other 4 conservatives vote against it, that means the lower court rule, which throws out the ACA, stands. And it's worth reminding everybody, the ACA is not just about the exchanges and the subsidies and pre-existing conditions, although apparently that's what Trump talks about the most. but also it's been a massive expansion, as Ian's been pointing out, over the years and over the months we've been having this show, of Medicaid. And what will happen? I mean, how this gets unrolled back is to me amazing. So can we start with that one? Because I would love our opinions on, is it going to get rolled back? Because we may find out pretty soon if the case is held in November. And then what does that actually mean for people in the healthcare system and everything? Who wants to start?
Well, I mean, it depends whether Biden gets elected or not, right? Because as I understand it from my colleagues at Levitt Partners who are deep in the weeds on this stuff, that it's a relatively, you could do it through action, a budget reconciliation action, because remember the individual mandate wasn't taken away. It was just zeroing out the penalty, right? So you could make the penalty 3 cents, and effectively that you put it back in and you're back to ground zero. But if they have already ruled and said that the whole thing is gone because of which is what the text ruling said, don't you have to pass the whole thing again? Michael, unmute yourself. Mike.
Matthew, I think you're right. If the whole thing goes, the problem is, as I understand court decisions, and I'm not a lawyer, you can't invalidate a law and then say, well, this law is no longer valid, but we'll give it a while until, it actually takes effect, right? You can't say, you know what, capital punishment is out, but you can execute a few people that you already had them in jail. What the heck, right? So if you invalidate the entire ACA, given all the provisions of it that you're talking about that we've all read, with the value-based purchasing and everything in the world, you cause instant chaos. As far as I can tell, right? Because just take one narrow provision that only we wonks know about: accountable care organizations, right? How many accountable care organizations are there caring for how many millions of Medicare patients? And if all of a sudden the authorizing legislation for that is gone, how exactly do you continue to pay people taking care of millions of elderly? And that's just something that, is out of the public eye, much less everything else. So, I can't say that I believe that people like Kavanaugh and some of the others, or Clarence Thomas, are particularly concerned about that. But the law is what the law is, and I think you cause utter chaos.
But that's their goal. Their goal in general, everything they do is to cause chaos. So what is the thing that will cause the most chaos with the least amount of work from them, right? And
that's a good way of putting it.
That's their dream. And that's when you have an opportunity for a dictatorship. That's when you have an opportunity for an authoritarian government, is by causing that chaos.
And actually, you raise a really good point there, Rob, that I hadn't thought of, which is, unfortunately, if the Supreme Court invalidates it before the election, then the administration, which caused this, then rides in to play good cop and says, you know what, we're coming in to save you from the chaos that the Obama administration caused by this terrible law, right? And people don't know that, what happened. And so they get the benefits of saving us from the chaos they created. You just made
hold on. Let's keep the calendar in mind. So it's not going to be ruled on before the election, right? The oral arguments are set for November 10th. It'll take months before a ruling comes out, right? So there's not going to be a ruling before the election.
Okay.
There's probably not going to be, I don't know the exact Supreme Court calendar, but it's unlikely there'd even be a decision announced before the inauguration, right? And there are lots of paths. Probably the most likely path from, I think, those who follow this is, even if they want to strike this down, to say that the $0 mandate can no longer be considered a tax, which was the original logic, right? And if it can no longer be considered a tax, then that portion becomes unconstitutional. And if you believe that it's not severable from the rest of the law, then the whole law has to fall. But when you walk through that complicated chain, as sort of frankly dumb as that whole argument is, there's a whole bunch of avenues for even the conservatives to simply say, yeah, we're going to strike down the mandate, but it's severable. and that has essentially no effect on the market.
You think that'll happen?
But don't forget that the other two, I forget the NFIB one, but the other, sorry, the others were 5-4, the main one was a 5-4 decision, which Roberts went on. The one about, and I forget the weird bit where there was the Michael candidate Cato was pushing all the time, but also got struck down, was also I think 5-4, I believe. And you know, so I'm kind of with Robin on this one. I think the conservatives on the Supreme Court are prepared to like burn the thing down. And then I think you get to the bit I want to play out. Let's go back to what Ian said is, all right, so let's say it's not severed. Let's say the whole, we don't know what they're going to decide. And they come up with an announcement sometime after the inauguration, after the new Senate. Then we're in the scenario saying, okay, is it a Biden presidency? Well, probably. I wouldn't put my life on it at the moment, but probably. Is it a Senate which has got 50 votes, you know, with the vice president for the Democrats? Well, looks like they're going to win Colorado. Looks like Arizona and Maine, but looks like they're going to lose Alabama, and the rest are real toss-ups. You know, so this could be back to a place where there isn't a Democratic majority in the Senate, even if there is a Democratic president. The Democrats will almost certainly keep the House. But I don't know how you pass anything unless you've got those 50, unless you've got those 50 or 51 votes. And you know, we're so I'm not sure you can. So if there is no severability, if they say, okay, the mandate, you know, you can keep that, but the rest of the law stands, which is the sort of logical thing you would say if you're conservative, that's fine. But if they are we want to burn the House down, which they were before, which they were back in 2013, you know, and again in 2015, or whatever I forgot the second case. I don't know. Yeah, there are so many, because there are things that you've forgotten about, right? The closing of the donut hole for Medicare Part D is in this. This massive Medicaid expansion is in this. All the stuff that Michael talked about regarding the ACOs and the way we're funding. Half of the stuff that Medicare is now pushing regarding sort of primary care capitation and that kind of stuff is based. I don't know where, you know, there is an argument of saying, do you expand the ACA, you know, go to single payer, do something different, do something wild, but to have nothing and then to roll it all back after.
I can't. I'm getting sicker here. My Apple Watch is like, breathe. It's giving me the alert. All I can think of is, you know, pre-existing conditions, and now we have this new world we live in where people have recovered from COVID-19, but they're really now starting to demonstrate all of these different side effects. People who even had a mild case are now having cardiac issues and are being having all these complications, being hospitalized. We have people who have been struggling with COVID-19 recovery for weeks, months, 6 months, long haulers who have never fully recovered, looking more of like a chronic disease. So now we have a new pre-existing condition.
Just to interrupt, Grace, what did Fauci say? 22%, or Rand Paul and Fauci are going at each other, and Fauci won the exchange.
He's amazing.
22% of people in New York City or New York area have now got. Does that mean they have a pre-existing condition? I think so, right?
Right.
We have a local hospital here that is just fantastic, and they opened a specific group of physicians got together who were on the front lines, who are now doing the long-term COVID-19 care. So it's a specific clinic and setup for it, which is fantastic, but we don't have that everywhere. And then how will people access it if we have nothing? So I did not have this on my bingo card. My bingo card is full of travesties. So we need to let this Hot Mess Express go to another train station, please.
Hey, Grace, I was speaking this week to several long haulers for an article I'm doing, and I'm really interested in what you're saying. What was fascinating to me and kind of dismaying was COVID. These people are being treated no differently by the healthcare system in terms of listening to them than anything else. I thought that at least with COVID, you know, I've talked to 3 long haulers, the doctors don't listen to them. In one case, you can't get a diagnosis of COVID because when you first had the symptoms, they wouldn't let you go to the hospital. And now that you've recovered, you no longer have the antibodies. So they say you won't have COVID. So you can't get any referrals or health insurance. They've got these chronic symptoms that they're being told you're malingering or whatever. Without a diagnosis, you can't get long-term disability.
Hold on. What about in our area? Most people couldn't get a test.
Right.
So they may have recovered.
Right. They couldn't get a test. They recover.
So
and
now
now
they're saying it's in your head.
Right. And the other thing that, as someone who's looked at the healthcare system for a long time, what was totally inspiring / uninspiring to me was I asked them 2 questions. I said, are the younger doctors any better than the older doctors? No. Are the women doctors any better than the male doctors? And the answer was, well, the women doctors say the message that we don't believe you much more nicely than the male doctors. And these are to the women. And it's just this, we don't believe the patients. And with the patient support group, you may have seen written up in the New York Times, Body Politic, they find other people like them. They find what to do about their symptoms. So it's terrific that you have a group of doctors who are there to really pay attention. That's just not true everywhere in the country.
So just to make it clear, though, that is not unique to the coronavirus. As a
Right,
GI
exactly.
patient, let me tell you, the first 10 years of my misdiagnosis were in and out. Hey, let's see the psychiatrist. Let's see this therapist. The stomach pain is in your head.
Right.
And then, this was until I had my large intestine removed. There was something wrong.
I thought they'd be better for the coronavirus. That was my hope. But they're consistent. They're consistent.
But if you look at a couple of things, I mean, so I think we're still back in the area where, and this didn't even come up in the first bit, right? But the Fauci Rand Paul exchange earlier this week, or like last week, whenever it was, which was around about essentially Rand Paul being the incredibly qualified medical professional he is, because he used to be an optometrist or something, ophthalmologist, taking on the world's expert on infectious disease. But put that aside, there's a whole bunch of people, we've talked about this before, who don't believe in masks. The governor of Missouri was appearing without masks. The governor of, the lieutenant governor or somewhere, North Carolina, that Trump showed up, told the crowd to put masks on, and they all booed him. And, you have that level of going on. But there is genuine lack of understanding, we just don't know, about a lot of the impacts of what coronavirus does to cardiac health and a bunch of other stuff. There's been a bunch of back and forth on Twitter amongst the cardiology groups and others about, should you be testing everyone? All the footballers at Penn State who got tested found that who were virus positive found they had implications for their heart as well. There's a whole bunch of stuff that clearly we don't know. So I can expect some uncertainty amongst reasonable uncertainty among clinicians. We're getting better at treating people with coronavirus because there are fewer people dying on the ventilators. People are getting younger and healthy people are getting it, have been the case in the South compared to where they were in New York earlier. But in addition, we're not certain about these long-term effects. I have a friend, Manish Junaga, who's on Twitter. He's in day 160, I think, of having long-term COVID, and he has waves, it comes and goes. But sometimes he thinks he's getting all better, and then other days he literally sits on the toilet and can't stand up. Well, he has to pull himself up. So I mean, you have all kinds of things going on. I think this is going to continue on because it's mutating, it's going to change, and then we have to come up with a vaccine. Robin.
It sounds like so those of us with autoimmune diseases, it sounds almost identical to what the people with the coronavirus have. I'm like, this is how I've been living my life for 30 plus years, right? And so I think back, okay, so maybe they should be treating this more like an autoimmune disease, like the long-term stuff.
Maybe. Ian.
Well, no, I was just going to say, what I'm taking from this discussion is that Robin's right, that the Texas, California lawsuit is like a neutron bomb. I think Dan's right that there's some, you've got to look at the pacing of it and whether there's some smart people on the court, even if they're conservatives, who say you can't put a neutron bomb on 30 million Americans. But I think we've all, in our different ways, said, look, the ACA has enormous tentacles through the entire healthcare system that almost everybody has come to terms with. So if this sucker goes down, there are 30 million people, to Mike's point, in either commercial or Medicare ACOs. Poof, 20 million people, 13 million people got Medicaid expansion. We're really going to get rid of that? It just goes on. And you compound that with saying, oh, let the states sort it out. The states are bankrupt, for God's sake. So, it is profoundly disruptive if it goes down. And you'd hope there'd be some adults in Washington who say that won't happen, but maybe that's the intent. I mean, Trump's going to come up with some, you know, fabulously signatured executive orders on Saturday, apparently, which are going to fix magically the pre-existing condition thing. But we may be looking at back to the future. I mean, remember that Washington, I think it was Washington State and New York State had, you know, pre-existing condition protection. And look at what happened in the individual market in those states. They were profoundly unaffordable. Just because you can't be denied doesn't mean you can afford it, right?
Especially if you take away the subsidies, right?
Totally. I mean, I remember giving a talk in Texas to the Texas hospital trustees, showing them what would happen with the Republican plan that was proposed. And the premium for a 60-year-old in Harris County was going to be $60,000. So, I mean, when you take, I mean, and this is where you get into, oh, well, the skinny plan's available, but it's not going to be available for somebody who's a long-term COVID member. I mean, so this thing is profoundly destructive. I mean, potentially, and the only backstop is adult supervision on the court, that they realize that they are throwing a neutron bomb if they actually pull it, and give enough time for Congress to respond.
So I like because we've kind of forgotten this, and there are probably, you know, people watching who've gone into healthcare in the last, you know, 10, 15 years who don't remember. But I mean, Ian, both you and I know, and Michael and probably everyone else in this went through the process of trying to figure out how to get individual coverage. Right. Number one. And also,
I joined a farm bureau, for God's sake.
and I remember when you were joining the Farm Bureau because your guy in health insurance told you how that was to get it. I remember being on and I said, can I apply? I'd applied to HealthNet and Blue Shield. I just had I had a short-term plan, so I was planning on abandoning the country, which I did do. And while I was doing short-term plan, I snowboarded into a tree. And poor Fortis had to cough up for my for my knee surgery. They weren't expecting that. I ticked all the boxes, and I didn't have diabetes, didn't have cancer, but you know, didn't tick the one which said I will not snowboard into a tree. So after I had my knee surgery, and I came back from my wandering around the world, and I applied to a bunch of places. Blue Shield said, "Oh, you had knee surgery? Yeah, no, you're uninsurable." And I said to eHealth Insurance, "Well, can I apply to a bunch?" And I think I applied to like 3 at once. And I remember having got the teaser rate for being good and well insured and having, this is 2004, 2005, having got the teaser rate, which was then like $90 a month, which the teaser rate now would be $500 a month. But anyway, I distinctly remember I applied it, and at the same time, I got underwritten by 2 or 3 plans at the same time. And 2 of them came back and said, you're uninsurable. And one of them said, no, you're great. So I took that one. I mean, and that was just random luck. But it was chaos, right? It was real chaos.
Matthew, my son, right, young and everything, was in New York before the law passed, and you know, working teacher or something like that with hardly any income, freelance. And I said, you need insurance, right? There were 2 plans. One was the affordable plan, and the other one was the unaffordable. But the affordable plan, which he took, had a little caveat, which of course I understood what it meant, but most people wouldn't, which it only covered care by the hospital's employees. So of course, if you were hit by a bus and they took you to the ER and, you know, there was an emergency room group that was, you know, contracted, you wouldn't be covered. And God knows how many other doctors like wouldn't be covered. And of course, unless you're a healthcare expert, you can't know that. And
even healthcare experts don't know that.
Right. I told him if he was hit by a bus, insist on being treated by the janitor.
Well, no, that's probably a consultant.
Right.
I remember Karen Ignani, who ran AHIP, and right. She gave a great talk at one of our meetings where she was talking about her husband, who's a health economist, who wouldn't get he was being dragged into the ER or the OR rather for some elective surgical procedure, and he wouldn't sign the consent unless he could get a written declaration that the second assistant surgeon was in network, you know.
No, really?
Yeah. No, it's
so I've got Ian, I've got one where a guy I know who is a health insurance agent, and when his wife, and this is back when, you know, very skinny policies, when his wife had the second baby, he wouldn't let her go to the hospital until she was actually ready to deliver. And when they tried to charge him for the room, like, were you prepared? I said, no, she went right into the operating room to deliver.
Oh God.
Take it off the bill. Oh,
take it off the bill.
So
I'm with Grace. Let's change the subject. This is
No labor, just delivery.
well, it's worth noting that the other thing apparently that Azar just said before we came on was there's going to be this the solution to pre-existing conditions. I think what Trump means is he's going to ban pre-existing conditions. He's going to ban diabetes and cancer.
Yeah, there you go.
He's actually
Or just kill them,
he's just going to ban them, and it'll go away like magic. But the other thing is they said they're going to do something. They're going to do something. There's be some recommendation around surprise billing, which, by the way, still is a big problem, even though the lack of access to insurance, and the cost of that is still an issue, not as it was. But that's been legislated to death, and there's been a lot of back and forth, and that hasn't ever been solved.
Well,
isn't that a sin? Isn't that a sin? Like, how is anybody okay with this? I mean, if you listen to people's stories, the reason you go to the emergency room is because you want to live and you don't want to die. And you really don't have the time. I mean, who's called an insurance company? They don't actually pick up and talk to you quickly and actually give you helpful information. You have to go through 9 different menus, hold for 37 minutes, and at least be disconnected and start the process over at least 2 or 3 times, because they don't do the callback thing efficiently. And then they tell you, you know what, you're not a member, bye. Even if you are a member. So how does this whole thing with the surprise billing work? How is that even a thing? It's completely unethical, immoral, illegal, all of it. And it's still a thing.
Yeah, no, and I think it was close to not being a thing, prior to COVID. But I think post-COVID, it doesn't go away. It gets even worse, right? For all the reasons you're all talking about. So I think this is a sleeper deal. And remember, for a lot of commercial actors, it's not a bug, it's a feature. It's their business model. You look at Zach Cooper's research at Yale, he basically unpacked all these ER private equity-backed roll-ups were basically dependent on an out-of-network strategy for their negotiation leverage. So I'm with you, Grace. It ought not to be a thing. And I think it's a bit like the RAND thing. I hope we talk about, because Dan's thought deeply about this, and I got in the middle of it, as I say, this week. But there's 2 ways to view transparency, in my view. One is you get shopping behavior, which I've always thought was complete rubbish. The other is outrage, right? I mean, Grace and I are outraged that it's a thing, and I think the public is much more on the outrage end of the spectrum with this stuff than.
Ian, have you seen any? I mean, I notice all the consumerism that everybody likes so much. I've not heard of anybody with COVID asking for a price list on the way to the hospital, but maybe I missed that. And by the way, leaving price aside, since I am a quality maven, nobody seems to be outraged that we can't get any quality information. We aren't mandating anything to do with people telling us about recovery of their patients, anything to do about long-term effects. Oh, and by the way, there is no national mandate on hand washing by healthcare providers. There's no goal. That they haven't looked at the hand washing rate. Literally, they haven't looked at the hand washing rate nationally for over 15 years. And there is no mandate to reach a certain percentage. All you have to do is show that you're trying to improve. So if you have a 10% hand washing rate and you're trying to get to 15, that's okay with the Joint Commission. And so even in the midst of this COVID thing, where hand washing has become like a mantra for the average person in the healthcare sphere, we have not required people to wash their hands to a certain degree. It's just ridiculous.
Well, healthcare is nowhere near as important as restaurant kitchens, and that's why the hand washing is mandated there.
Guys, my second graders class has mandatory happy birthday and twinkle twinkle little star, for the 20-second hand washing. And the kids hold each other accountable. And actually, Michael, I'm more concerned about the smart devices in hospitals, not just the hand washing, because people wash their hands and then they reach into their pocket and pull out their dirty device, and then we're touching everything. So I think we got to one up the hand washing.
All right. So I want to wrap the bit about, maybe not the wrap bit about the ACA and the rest of this and all the impacts of this. I would just remind you, if you really are bored and want to go back in the healthcare blog, I read a long series of things about a company called Health Markets, which was basically a fake insurance company selling fake insurance plans that's likely now to come back with the short-term stuff. And what their little trick was, a very clever one, was that they would pay for your hospital care, but the maximum was like $150 a day. So if you got in the so essentially they were selling fake insurance. And at one point, the CEO of Health Markets, you mentioned Carignani, not somebody I have a massive amount of respect for, Ian, was the chairman of AHIP. So it's not like they were a double fly-by-night organization. Right. And that's maybe what we're coming back to. All right, I'll shut up about that. Ian, Dan, tell us about RAND. What's those of you who haven't been following this, what's going on with the RAND 3 stuff?
Well, let me just tee up and give a shout out to Dan. So I wrote that thing, The Game. I think we talked about, the German Minister of Health and the prices. So I was giving a talk to John Muir. Then the RAND thing came out, and Arnie Milstein called me up and said, could you frame how people are thinking about this, people being health systems and employers? So I had a conflict with timing. So I just did a quick intro, but the guy, the lead author from RAND, presented to Arnie's group yesterday, but he gave a shout out to Dan's analysis because he was going through his shtick of what they did. And I'll explain what they did in a second, then Dan can riff, but he showed Dan's very powerful subsequent analysis of California hospitals related to quality measures. So here's the bottom line with the RAND thing. They got data from every state. They got data pretty much from every hospital because they used self-insured employers data sets. It's not the charge master, it's what they actually got paid. And they name names all over the place, right? And it's really carefully done. Now you talk to hospital CEOs and they'll all say, oh, false methodology, blah, 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 blah. We've all heard this stuff before. It's directionally correct. And it bears out in my experience over 40 years. And we're talking about a massive price increase over time. And the levels are unconscionable and unrelated to quality and outcomes as far as we can make out. It's all over the map. There's some slight effect. But anyway, Dan, you've looked at it closely. And I do think this is a game changer. And my work with the employers has been, they're starting to see a sense of outrage about this, that we've got to do something. So it may have galvanized them on that part.
Yeah, I mostly agree with that. I think you mentioned John Muir, if I'm not mistaken. This study shows John Muir as the highest priced health system in the entire country.
No, really? Yeah. So what was that? So the average was what, 250% of Medicare, and what was John Muir at?
Well, they're over 400. Now, look, come on, be fair now. They are in the middle of the most concentrated market in America, right? So Northern California is 40% more expensive than Southern California, and it's all price, right? I mean, what we know about everything is that the North is smaller volume, higher prices. The South is higher volumes, lower prices, relatively speaking. So it's situational, and it's.
Well, hold on. I think, yes, it's true that Northern California has historically been much more expensive than Southern California, and that consolidation is a big part of that story. But UCSF is also in Northern California, and they're 200% of Medicare. That's half. Right.
And so you could argue they're leaving money on the table. This is why this thing, if I was Mark Lara, I'd be saying, what the hell? Why am I not charging what Stanford's charging? Like, I mean, Pat Fry, who ran Summit at Sutter, rather, taught me well 20 years ago. He said, if you're not going to move, and this is the question I have for the patient advocates, if you're not going to put a benefit design in place that moves business away from me, I'm not giving you a discount. I'm sorry. And he's right. And so it really comes down to giving, if you're going to play this transparency shopping game, you've got to design something that puts a penalty on you going to those high priced places. And that penalty has got to be very high, in my view. And I don't know whether that's the right way to do it. Rather than just legislating, you can't charge that.
Yeah, I tend to agree. I personally think that the downsides of trying to solve this through one-on-one negotiations between plans and providers, there's no real evidence that works over time. I mean, in any country, there's no place where that has worked well, at least. There are selected cases where it works in highly competitive markets, primary care, some imaging stuff. But for hospital services, I think there's no good example one-on-one provider negotiation solving this.
There are some factors though going on that really are pulling patient care out of the hospitals and clinics. Let me give you two examples. CMS launched their ET3 program. It's supposed to take effect. It's been delayed a little bit. It's supposed to take effect this fall, so anytime now. And it is for, they've partnered with ambulance companies and hospitals with ambulances. And so it's now, instead of going directly to an ER when someone calls 911, if they can take care of the patient in place, they do. If the patient needs to see someone beyond the nurse and the technician that come with the ambulance, they call a physician over video right then and there. And if they can take care of it, they do. If they cannot, they then go to primary care and or urgent care, and they take the patient to one of those two places. And if they cannot take care of it and it's too serious for that, only then are they going to the ER. And this is a 5-year voluntary payment program that is now launching. But the other one is companies like United. United, again, largest of the private payers, Fortune 500 company, Fortune 5 company, and they've got about 50 million patients between here and of course places like Brazil. Now they have banned Remicade, the medication I've been on for 20 years. They've banned it now completely in hospitals. If you are one of their patients, you are not allowed to go to Stanford or Palo Alto Medical Foundation or UCSF to get this. It will not be paid for. Now, the difference in price, I used to get it was $28,000 per dose when I was getting it at a hospital, and now that I get it in home, it's $2,500.
Yeah,
but one of the biggest disasters, excuse me, is when a patient goes to the ER. That a lot of patients with chronic conditions refuse to go to the ER for that reason alone. They don't care how crummy they feel because they're afraid to mess up. They have titrated and been carefully managing their medications, and now it's all going to go to hell in a basket like 10 times over. You can't bring your own medications in. You can't do your own dosing. You can't have your loved one help you, even though you know all of the nuances. So it's crazy.
I want to reinforce what Dan said about the employers or the payers negotiating against the providers. I mean, as a former benefits consultant, I remember the saying, make sure the CEO's wife's gynecologist is in the network. And when you look at the human factors, the fact is that companies are not in the healthcare business, and they're very reluctant to go head to head, even with the Leapfrog Group. We've learned that, against providers who have a halo, even more so now after COVID, right? We're clapping, we're doing everything else like that. And they just, secondly, even if they weren't for the public relations, their executives are on the boards and all the rest of that kind of thing. And so, they're just not in that great a position. And the coalitions that we thought would do it, all the business groups on health and this, that, and the other thing, just never did. I mean, even the Pacific Business Group on health, right? The most progressive and the most knowledgeable, and all the people we know who ran it, who were the smartest and had a huge number of lives, they're just not going to take them on. And we know that. And we've been waiting for them to take it on, and they made good speeches. I remember even for the Leapfrog Group, which does patient safety, right? I remember being in a private meeting with Paul O'Neill, of blessed memory, of Alcoa, right, with other CEOs at one of these private business clubs in Pittsburgh. And he was trying to get them to buy into zero harm from the Pittsburgh Regional Healthcare Initiative. And they said privately, look, if we direct our patients to certain places, or we say they're good on safety or quality, if something goes wrong, they're going to sue us, which of course is silly, but goes to the point. They don't want to direct patients because they're afraid any consequences, even if unjustified, blaming them will be a PR nightmare, especially after the 1980s. Not all of them, but a lot of them, most of them. And as Dan said, and as Ian said, it's just not a game anybody's won.
Oh, and that's ridiculous here, because patients should have access to that information to be able to choose where they need to go and get their care. So nobody actually has to send them anywhere. The information, if we were really transparent and had the information out there so people could make an informed, educated decision as a consumer, as a health citizen, wouldn't have this problem. But we're not really in the game of transparency. We're in the game of making money.
What you said about restaurants, Grace, right? I would say cut out all the quality measures and just in the lobby post the infection rate as ABCF, like with the restaurants. One measure in the lobby.
Dan.
I just have two thoughts. One, we should probably update Michael's analogy to be the CEO's husband's urologist.
Yeah, because there's so many female CEOs, you know, Fortune 500.
Second, we have at this point been working on price transparency for a long time. So with all due respect to, I sort of agree with Grace's theory and sort of philosophy of patient empowerment that this is not a new idea, right? When did Castlight go public, right? We've been working on this for a long time and we sort of know what the impact is. So at this point, the price transparency story is largely, I would argue, used by folks who come at this with a philosophical or an ideological leaning, like Rand Paul, who says every bit of healthcare should work like LASIK. Well, it's not like LASIK, right? And we know what happens when we put price transparency out there for consumers. It's a positive effect, but on the order of 2 or 3% cost savings, right? It's been studied to death. It's not bad, it's good. It can have some effect on certain outpatient services. It can certainly improve competition from a low baseline. But ultimately, that's not going to be the answer when you're talking about $30,000, $50,000, $80,000 price differences between hospitals that are 20 miles apart.
Right. So let me put 2 little wrinkles on this and just discuss. I want to drag it back. I'm doing one of the clever things where I'm going back to something I said a long time ago. So there are 2. One thing we said, we had Jen Benz on with some of you on, who's an employee benefits consultant and explainer of employee benefits communications for big companies, and she has spent a lot of time was talking about centers of excellence. We know that Walmart and among others are kind of going around the sort of reference pricing, going all the way to centers of excellence, moving people to when, Robin, they have to go to a real hospital for whatever it is, rather they can't deal with the people sort of redirecting them to the urgent care center or whatever. You know, you have to go to the 3 hospitals that Walmart has got a good deal with, right? And whether that's going to grow as an area. The other one is to bring it back to what I said earlier, right? So who went public this week? GoodRx. What does GoodRx do? It takes all the mess that is hiding behind pharmacy pricing, right? And basically says, well, you know, this PBM or MedImpact PBM has got a deal with Walgreens. And if we, instead of just letting the poor patient walk into Walgreens and pay whatever Walgreens thinks they can get away with because they're paying a cash price or it's under deductible or it's not covered or what have you, we will essentially give them the coupon that is the MedImpact price. And we'll, you know, MedImpact will make a bit of money. We'll get a bit of the money MedImpact makes. And yeah, Walgreens will make less, but otherwise the person's going to walk out the door and go somewhere else or not buy it. So Walgreens will kind of take it like it's a Groupon coupon for them. And that's why they've been fantastically successful in growing to a lot of people. Is there a possibility that if you actually put cash on the line somewhere in this process to the patient, and there are a couple of startups that have tried this, one, by the way, not in healthcare, but in called Trip Actions, doing this for corporate travel, where instead of, you know, in the old days when I worked for Ian and I would, actually, you may have forget this, Ian, there was a deal that Bob Johansson put in the Institute for the Future, where if you, back in the 90s when we were there, if you flew back and forth from the East Coast, West Coast to the East Coast in the week, the airlines would charge you like $1,500. But if you went over the weekend and stayed a Saturday night, you remember this? The airlines would charge you like $300.
Oh, yeah.
And Bob, I mean, somebody, wasn't Ian because he didn't care, but some of the institute said, oh, if you stay over the weekend, we'll let you spend 50% of the difference that you save. And I was the only single person who worked at the whole place. And I spent like weekends in New York and Miami. At one point, I remember, I'm not sure how good the accounting was. I went to Miami, I went to the High Lie, and I gambled and I had some losses. So I put that expense brought in. I got paid back. Don't tell my boss. Oh, hang on, he's saying that. but you know, basically, the Trip Action is doing the same. It's doing the same thing. It's basically saying if you were to go somewhere and spend the $500 a night hotel, if we find you a $300 a night hotel, you know, you keep $50.
So Matthew,
is there a way we can do that in healthcare? Is it possible?
Matthew, the problem with the analogy you make with GoodRx, which is what I would agree with Dan, all the philosophical people do it. What about this? What about the scan? Everything. Yeah. There's a difference between a standardized product and a service, right? So if GoodRx said, you know what, the drug you get at Walgreens costs less. We can't promise it's the same quality of drug, but don't worry about it. Right? And so I wrote a column during the Bush administration, Bush 2, where for you, as a matter of fact, talking about the fact that we'd have discounts, right? Advertising. But if you take that $9.99 price, you get the doctor who recently retired, anesthesia is extra, you know, all the stuff, right? And so if you ever price shop for services, you know, how are you going to do it without decent quality measures? I price shop. So my wife needed an MRI that was basically like, you know, the doctors don't sue me and you probably don't have anything, and she was anxious, right? So okay, so I know this is like something on her back that she doesn't have anything. So the healthcare system that we use, she had to wait a week. You know, Medicare, you can get it paid for. So I did the shopping thing and went to some place with an MRI that was in a shopping center, and you know, great service and all the rest of that. But I asked questions about the strength of the MRI and who was reading the MRI, which was Cleveland Clinic people, you know, moonlighting, right? How many people are going to ask those questions? And that's a product, basically, not even that much of a different service, okay? And so all this sort of shopping thing for services, I invite you the next time you need a surgical procedure to simply ask for comparative outcomes of the different surgeons near you. Maybe their infection rate, maybe their, you know, functional status for your next knee procedure, and see how well your comparative shopping goes. And the data shows that what do people do? When they don't have information, they figure the guy who's more expensive is better, right? He must be better. That's why he's charging more. And so this whole thing where people say good RX or X-rays or MRIs is just piffle. It means nothing compared to what we really spend money on.
All right. Well, I've got to tell my funny story about how I defrauded Ian from $50.
Yeah, no, I'm happy to hear it. That's why we were non-profit.
Oh, that's why we didn't make any money anyway. Yeah. All right. Well, let me. While we're on the, we have 10 minutes to go, and I want to raise one other thing that hasn't come up, but is, you know, going to come up a hell of a lot in the next few weeks. So let's assume we get one of the people on Trump's list, including the extreme Catholic, whose name I'm blanking on, confirmed. And maybe it happens before the election, maybe it happens after the election, but let's see. There's a bit of healthcare we don't talk about a lot, but is absolutely in the crosshairs of those right-wing conservative, you know, reconstruction, what do you call it, constitutionalists, which is the issues around abortion. So what happens to Roe v. Wade, and what happens to you know, women's reproductive rights and healthcare? What's, I guess, and how is that going to happen while there is a, you know, even if there is a Biden administration? Does anyone have a sense about how that's going to play through? Because I think that's what, you know, if you're going to rile up the base on the Republican side and fill that seat and all that stuff they're talking about, that's what they care about. You saw an article in the New York Times about Trump voters in suburban Wisconsin. That was the big issue.
Women will die.
I'll give you that. How do you think?
Women will die.
No. I don't have to go into that. What I'm asking, Robin, is, you know, what do you think the response could be on the legislative side if there's a Democratic House, Senate, and President, and yet Roe v. Wade gets struck down, which will happen?
I'm anyone's guess at this point. I mean, they'll give, I'm guessing if there's a lot of conservatives, they'll try to give more power to some of the more conservative states to just really, you know, shove those laws down a lot of the time. I mean, they're already doing that, but I would think it would just become much, much harder. But I mean, I don't know. That's the thing, is that they've created such chaos that the rules no longer apply. The things that we thought would happen 10 years ago and we could project, these things no longer apply because they are not playing by the same rules that we're playing by.
Well, and you've seen, was it Indiana and Alabama and Georgia all had sort of, you know, extreme laws passed that all got knocked down in federal court because of Roe v. Wade.
Yep. And those will all pass, right? Now, if that's gone, that's what I'm saying. The states are going to get harsher. The conservative states, it'll become more and more dangerous to be a woman or a minority in a conservative state. Come to California.
Matthew, I'll toss out two thoughts that I think are a little, maybe with a slightly more positive spin. I mean, just to be clear, this would be a very unhelpful and destructive policy direction, and it would hurt a lot of people, particularly poor people. That said, there's a little bit of this that's the dog that caught the bus, right? So the Republicans have spent decades making this into a national issue. It's an issue of state policy. All Roe does is block states from doing something that some states want to do, right? There is an argument that the long-term fix is to win the argument at the state level, right? So Democrats, to some extent, have gotten comfortable because there was a protection from Roe. And the community organizing and the persuasion that needs to happen in southern states so that this is protected by legislation voted on in state legislatures, sort of that, a lot of that groundwork hasn't happened. And it might be healthier if we got to a place where it did happen, because you'd end the argument by winning the argument instead of letting it fester and turn on a couple of unelected sort of quasi-legislative seats on the Supreme Court. The other spin, of course, is abortion just scientifically is less important than it used to be because we have more technology options here. So from a federal policy standpoint, what could the feds do? There are things you can do to make the morning after pill more available, to make contraception more available, right? Those are things that there's very little question the federal government can weigh in on. And so even if the court says, well, you can't block states from making access to abortion problematic, well, then the question is, well, we now have alternatives that the federal government can lean in on. And I think that could be a path that you'd see.
I'm trying Dan being the optimist on the show today.
Trying to help.
We're working on this week. Michael.
I really hope you're right, Dan, truly. The thing that disturbs me about it is, and would be interesting as it were, there are two things. One, it raises the issue of the extent to which we use religious belief to make laws, right? And so if due to deep religious convictions, states would ever outlaw abortion, well, I respect that if there was a Muslim majority. What about, that whole conservative field of fear of Sharia law, right? And by the way, Orthodox Jewish belief on abortion, while it's undesirable, is not the same as some of the Christian fundamentalists. And so, it really starts to raise religious issues, which is unfortunate for the country to start to look at it that way. The second thing it does, which in my view is actually fortunate, is it, and as a correlate, is explodes the myth of a woman's issue, right? Because if all women felt this way, you'd have 51% plus what men. And the fact is, as far as I can tell, the only women's issue is whether the toilet seat should be left up. Women governors have done this. So what this does, to sort of be optimistic with what Dan says, it forces people to deal with certain issues realistically as opposed to with slogans. And I guess that's a good thing, and maybe at a state level. So I hope that Dan's optimism is the road that the country takes, as opposed to tearing itself apart in more ways.
Well, we'll be talking about, so if I remember her name, Amy Coney Barrett, who's the likely nominee. We're going to hear a lot about extreme Catholicism and potential cults and God knows what for the next few weeks. But unless Mitt Romney has a sudden change of heart or something else changes dramatically, I don't see her not being seated in the way that's supposed to. Unless, who knows? Potentially, Nancy Pelosi re-impeaches Trump and tries to sort of gum up the calendar and run out the clock. But we're going to hear a lot about this for sure in the next few weeks. And I think while we're worried about the ACA, rightfully so, it's going to be Roe v. Wade, which is going to get the headlines. All right. With that, it's time to wrap for the week. So let's just quickly go around and say, let's hope next week is more calmer, more peaceful, and more serene, although I doubt it. So what are you looking for the next week? I'll start with you, Grace.
So continued transparency on vaccine protocols, data that's being collected. And we also had a new entrant going into clinical trials from J&J, which is a potential vaccine candidate that would be one dose, and it's more stable, more favorable. So I'm looking to see more scientific evidence that's going to boost more medications, boost our trials, boost the science so that we can get out of this mess, or at least start to live with it.
Dan, what are you looking for the next week or so?
I'll be looking for more sort of follow-on analysis on that RAND study. I think it's just opens up a bunch of interesting doors, and I think we'll all be focused on the sort of flow of news on the vaccine trials, and then of course the future of the ACA.
Robin.
So I like to be able to sleep at night, so I'm not really watching the news on the politics.
That's what you should do, Grace. That's the solution.
But I am watching heavily the remote patient monitoring with Apple Watch now coming out with the SpO2 blood oxygen monitoring, and they've already got their single lead EKG. They are making this mainstream. It's being reimbursed by CMS. I'm excited.
All right, Michael.
Well, unfortunately, I watch the news, so I think, Matthew, you've nailed it. We're going to hear talk about vaccines. We're going to hear talk about Roe v. Wade and the ACA. And while in the background, all these other hopeful things are happening, in the next week or so, or few, we're going to be dominated by these other issues. God help us, and not sleep well.
There are a couple of digital therapeutics, as they call it. I hate the term, but which aim precisely at your problem. Big Sleepio is one that perhaps we should be prescribing that in the water. Ian, your expectations?
I'm watching to see President Trump's health plan unveiled over the weekend, which is going to be a 3-paragraph executive order, and he'll still manage to get 18 holes in.
Well, I'm going to close with I have no idea how to do any of that. I mean, I can't remember in a week this quite eventful, and God knows we're probably going to have. It's probably going to ratchet up. It'll be like the Tesla stock price. You can't be going any higher, but it's got going up. There was a question on the chat from Kim Bell, and I thought, and it's a funny one. And this is sort of an underlying one which I think we've got to think about for the whole of health policy as going forward. And Kim said, if those Northern California hospitals are so expensive, why? And if Kaiser is so good, why isn't it a whole lot cheaper? Which reminds me of something Mark Smith said years ago about healthcare. Don't talk about blending the curve and coming down to make it cheaper. And I don't know if there are any signs towards making it cheaper, but we've had some discussions about that today and a whole lot else. Wow. So this was a long and quite explosive THCB gang. So to wrap it up, I really want to thank my guests, who are again Grace Cordovano, board certified patient advocate from the New Jersey area. Robin Farmanfarmaian, he's CEO of, co-founder of Face Touch Aware, another Apple Watch tool, which will help you stop touching your face, which apparently is bad for you, he says, doing it now. Now I think about it. Michael Millenson, from President of Health Quality Advisors from Chicago. Ian Morrison, health futurist, and the boss who never found me gambling and expensing it way back when. And Dan O'Neill, RWJF fellow and healthcare consultant from San Francisco. It's been the THCB gang. We'll be back with another episode of the THCB gang. This time, same place, 1 o'clock Pacific, 4 o'clock Eastern. And I want to thank the THCB sponsors, who include Livongo, One Drop, Teladoc, and Bayer, for supporting the blog and the show. And with that, we'll see you next week.